Good morning, everyone. Happy rainy Wednesday. Very, very excited to have a HIV primary care focused talk today from two experts that I'll briefly introduce. Dr. Chris Bositis joined the faculty recently in the Department of Family and Community Medicine as the clinical director of the National Clinician Consultation Center that many of you have either worked on or called most likely, and is a new member of the Ward 86 urgent care team. Before he was at UCSF, he led the HIV and viral hepatitis programs at the Greater Lawrence Family Health Center and has provided primary care across the lifespan. Dr. Jessica Bloome will be our next speaker. And Jess, as I'm pulling up your bio here, is sorry, Jess, if I can. Well, Jess, you can, I was going to give you, are you an associate professor in our division? Assistant professor, thanks. My email is failing me. In the Division of HIV, ID, and Global Medicine at San Francisco General. She directs the FAST program, sort of welcoming new patients living with HIV into HIV primary care, and is also the deputy director of, tell me your title, Jess, at SFDPH. Or you're the deputy director of what at SFDPH? Amazing. Thank you. Capacity building. Thank you for my email fails. We will hear a phenomenal case-based talk from these two today. And please feel free to put questions in the Q&A if you're joining us online. If you're in person, we'll probably hold questions until the end. There's a lot of content, but hold on to those questions and we'll get to them. Thank you both.
Thanks so much, Aisha. It's really an honor to be here today, presenting to you all about what's hot or not. Oh, there goes the camera. In HIV primary care. Hopefully that will stay up there. And so Jess and I have just a couple of disclosures that we wanted. Oh, I don't know why that's not working. It's not advancing. Let's see. Oh, wait, it's this. Okay. So, no. Okay. Joe. While he's bringing that up, or while he's trying to troubleshoot the slides here, we have just a couple of disclosures that we wanted to make sure that we went over ahead of time. The first, try now. Oh, there. It's okay. Okay. I think we're good. All right. So the first is that we are actually not experts in any of the particular domains that we're going to be talking about today. And we recognize that each topic that we touch upon probably deserves an entire talk on its own. Having said that, we chose these topics because they are topics that influence our daily practice as experienced primary care HIV physicians. Secondly, we also wanted to highlight the fact that the cases that we're going to discuss are loosely based on actual patients, with several details modified for teaching purposes. Okay, so our objectives for this morning are first to name at least 2 negative consequences of internalized weight bias. Second, to describe the recommended testing to diagnose type 2 diabetes in people who are taking antiretroviral treatment. Third, to discuss some of the commonly used first-line agents for people with type 2 diabetes and some of the key differences between them. Next, to describe when and how to screen for metabolic-associated fatty liver disease in people with HIV. And lastly, to review recent updates in the guidelines for the diagnosis and management of people with lower urinary tract symptoms, as well as to review recent updates in the USPSTF screening recommendations. So launching into our first case, LR is a 55-year-old cis woman who was born in the Dominican Republic and diagnosed with HIV in 2007. And she's coming to your clinic today with concerns about weight gain. Again, she was first diagnosed with HIV in 2007, and she started Atripla shortly after her diagnosis. She suppressed virologically within 4 months of starting her treatment. And she states that she generally tolerated this treatment well, except for some vivid dreams. In 2014, however, she requested a change in therapy because of the fact that those vivid dreams were increasingly interfering with her sleep. And so the decision was made at that time to change her to Truvada and dolutegravir. She remained virologically suppressed both before and after the switch. And then in 2018, she again requested a regimen change, this time to decrease her pill burden after she heard about Biktarvy. So we changed to Biktarvy at that point in time. Her past medical history is notable for hypertension, for which she takes amlodipine, 10 milligrams, and she also has a diagnosis of obesity with a current BMI of 33. So on further questioning about her weight gain, she states that she first noticed the weight gain a little bit of weight gain when she started the Truvada and dolutegravir, but it was really apparent after she switched to Biktarvy. And after you do a chart review, you confirm that she has in fact gained about 20 pounds since making that switch in 2018. Importantly, she also tells you that she's experiencing a lot of shame and anxiety because of this increased weight, stating that she can't even look at herself in the mirror anymore because of it. So moving to our first audience response question, which of the following statements about internalized weight bias in this person is false? 1, IWB is a risk factor for further weight gain. 2, IWB is considered both a cause and a consequence of obesity. 3, IWB is strongly associated with depression and other negative mental health outcomes. 4, there is currently no validated screening tool in clinical practice for IWB. Or 5, IWB may lead to a poorer response to both medical and surgical treatment for obesity. A couple seconds. All right. So we have a good variety of answers here. Looks like it's still moving. I'll give you another few seconds. Okay, great. I'm glad to see the variety of answers. The correct answer is actually that there is actually a validated screening tool for IWB, and we're going to talk about that in just a second. So, as you know, at a recent Ward 86 provider meeting, Monica mentioned that it's no longer possible to talk about ART without talking about weight gain. And as I was thinking about that and the implications for our patients, I came across this consensus statement that was released in 2023 by the American Association of Clinical Endocrinology on addressing stigma and bias in the diagnosis and management of people with obesity. And if anybody has a chance to read these in full, I would encourage you to do so, because I actually think that they have the potential to be truly practice changing. One of the things that they emphasize throughout this consensus statement is that in order to be able to effectively address the problem of obesity in our community, we have to address the problem of stigma. And this figure here, I think, really nicely displays the complex and often bidirectional interplay between internalized weight bias, that feeling of shame and stigma that people feel because of their weight itself, external weight stigma, some of the psychological effects experienced by people who are overweight, including anxiety, depression, and disordered eating, as well as their response to therapy, leading to a vicious cycle that kind of repeats itself and exacerbates the problem of obesity. And one of the things that I wanted to highlight here is that while external weight stigma comes from a variety of sources, I think that we as a healthcare community need to be honest about the role that we have played in exacerbating this weight stigma. Fortunately, I think that we can also help break that cycle by starting to recognize the importance of screening and treating this problem of internalized weight bias. And we're going to talk about how to do that in just a minute. But before I get there, one of the key factors, or one of the key approaches that the consensus statement notes that will be helpful in breaking this cycle is changing the paradigm of how we treat the problem of obesity in practice, from the current weight-centric approach to a more complications-based or chronic care approach that focuses on the complications of overweight or obesity, which are listed in the table on the left of the slide here. And by doing so, we can change the goals of treatment from specific weight-based targets to more neutral and clinically meaningful outcomes, like validated clinical targets, like the A1C or blood pressure targets, or symptom frequency scores, depending on the specific complication. I think another reason that it is so important for us to change this paradigm is because it acknowledges that the traditional weight-based approach to caring for people with obesity has perpetuated stigma and racism by failing to recognize some of the known ethnic differences in BMI, and by failing to recognize the complex neuroendocrine and behavioral factors that underlie an altered adipose set point. So there are 3 specific steps that we can take in practice recommended by these AACE guidelines to help us in this process. And the first is simply to change the way we have the conversation with people who are overweight by taking a more motivational interviewing approach type process to the conversation, and using this paradigm that they call the 5 A's for obesity. The most important of which that I will highlight here is that we want to make sure that we're asking folks if it's okay to talk with them about this issue and the potential health complications that can occur as a result. A second step that we can take in practice is to begin measuring waist circumference in everybody that has an elevated BMI, because we know that that is actually more accurately reflective of the risk for metabolic complications in people with obesity. And so they also recommend that whenever possible that we should be using ethnic specific guidelines or norms for BMI and waist circumference. And lastly, they recommend that we screen for internalized weight bias using a clinically validated tool like the Weight Self-Stigma Questionnaire, which is shown here. And of note, this questionnaire has been translated into multiple different languages that you can find online. Okay, so we're going to move on to the next segment and bring us back to our patient. After reviewing how to check the waist circumference, your patient reports that hers is 34 inches, which is a little bit elevated. So you talk about the potential that has for, that indicates for cardiovascular complications, and you review lifestyle and other potential interventions to help address this. So you also obtain her yearly health maintenance labs, including a lipid panel and a hemoglobin A1C, and her A1C comes back at 6.6. So for our next audience response question, at this point, would you, 1, start metformin for her newly diagnosed type 2 diabetes, 2, start semaglutide for her newly diagnosed type 2 diabetes, 3, check a fasting glucose, or 4, repeat the A1C in 3 months? Okay, fantastic. So it looks like the majority of folks are choosing the correct answer here, which is to check a fasting glucose. And the learning point that I wanted to make is that in people who are on ART, A1C alone should not be used to make the diagnosis of type 2 diabetes. And that is highlighted here by both the HIV/MA primary care guidelines published in 2020 and the recent ADA standards of care and diabetes guidelines, which emphasize that plasma glucose criteria should be used to make the diagnosis of type 2 diabetes in people who are on ART. So why can't we use A1C alone to make the diagnosis? The answer is that multiple studies, including two that I've highlighted here, have shown that in people who are on who are on ART, the A1C unfortunately just does not correlate very well with true levels of glycemia. And the mechanism for this is not really well understood. The most common finding is that the A1C tends to underestimate true glycemic levels in people who are on ART, but the opposite has also been found, especially for people who are taking boosted PIs. And again, the mechanism is not clearly understood. For some agents, including the early NRTIs, it's felt to be related to the elevated MCV that you can often see, which reflects the presence of more immature red blood cells and suggests a shorter erythrocyte lifespan, which is going to impact the A1C level. But even for agents like 3TC that do not lead to an elevated MCV, we see the same effect. And in those, there's some thought that maybe subclinical hemolysis might have something to do with it. But again, in general, not really well understood. I also want to highlight that we do not have a lot of information on how the newer INSTIs impact the correlation between A1C and true levels of glycemia in our patients. So since the current guidelines recommend using plasma glucose-based criteria to diagnose diabetes, I just wanted to quickly remind everybody of what those are. Again, if you have a fasting glucose of greater than or equal to 126, a 2-hour plasma glucose of greater than or equal to 200 after a glucose load, or a random blood sugar greater than or equal to 200 in someone with hyperglycemic symptoms, that is how you diagnose type 2 diabetes. Importantly, for all but the last one, you need to confirm an abnormal value with a second abnormal value in order to make the diagnosis. A couple of quick caveats about this recommendation. The first, as I mentioned already, we don't have a lot of data about the INSTIs and how they impact A1C in our patients when we're screening for diabetes. And the second is once the diagnosis of diabetes is established, current guidelines do recommend using the A1C to monitor the response to treatment. So how do I put this all into practice when I'm working with my patients? Well, I have stopped checking an A1C every year with the health maintenance labs. And instead, I check a plasma glucose. And if that is abnormal, once I have confirmed the diagnosis of diabetes in that individual, then at that point, I check the A1C. So moving on to our patient again, you obtain repeat labs which confirm the diagnosis of type 2 diabetes. And she has some other notable labs done at this time, which include a normal platelet count, a mildly elevated ALT, a borderline AST, and a normal creatinine and urine albumin to creatinine ratio. My next question is, which of the following agents would you choose as initial therapy for this person? Would you choose pioglitazone, metformin, empagliflozin, or dulaglutide? Yes. Yep. For A1C, that's a great question, and I actually wondered that myself. The current guidelines don't make any specific note of it, however. But theoretically, it is the same concern, at least with Truvada. All right, great. So I see a good variety of answers here, which is encouraging because actually any one of these agents would be potentially be a reasonable choice for first-line treatment for these patients, for this patient, which is actually very different than just a few years ago when the recommendation was pretty much to start everybody on metformin. However, the most recent ADA guidelines state that there is allow for a lot of flexibility in the choice of that first agent, depending on what your specific goals of therapy are. And they have a really nice figure. I think, in the guidelines, which I wanted to highlight here, which kind of break down what those goals might be and how that influences your selection of a first agent. If your primary goal is simply the A1C lowering effect, then in that case, you're probably in most cases going to go with metformin because it is a fairly potent agent at lowering A1C, and it's also inexpensive. However, they do note that it is not the most potent A1C lowering agent. So depending on just how far above goal you are, you might want to consider other agents like the GLP-1 RAs. For people in whom weight loss is a significant component of your goal, then GLP-1 RAs are a great option. And then for people who have comorbidities like atherosclerotic heart disease or heart failure or chronic kidney disease, other agents like the SGLT2 inhibitors are also on the table. And this table here, which I've adapted from the ADA guidelines, I think includes several of the different characteristics of these medications and can really help guide us as we're trying to choose the appropriate first agent for our patients. And I just wanted to highlight a couple here. So metformin example, again, potent A1C lowering, orally administered and low cost. And these last two columns I think are kind of really important to keep in mind because they are characteristics that matter a lot to our patients, but maybe less of an impact in terms of the cardiovascular or renal effects. Although I would remind everybody that the UKPDS study showed that metformin does have a really positive impact in terms of reducing both diabetes-related and all-cause mortality in people with diabetes. So again, often a really good choice for a first agent. The GLP-1 RAs do have a lot of other benefits, including specific benefit in people with cardiovascular disease. They are also very effective at causing weight loss and lowering the A1C, but they are costly and in most cases require an injection either daily or weekly. And so some people just don't want injections. And so that might not be the ideal option for them. And then the last agent that I'm going to highlight from this table is a pioglitazone, also fairly effective at lowering A1C and has been shown to provide benefit in people with biopsy-proven metabolic-associated steatohepatitis, but can cause weight gain, and there's a potential for increased heart failure risk. So you have to keep that in mind before choosing that agent. So just to point out, this again was adapted from the ADA guidelines, which has a more complete table with even more comprehensive information that is, I think, really helpful as you're going through to choose that first agent. In terms of resources to help you keep all of this straight in your mind as you're trying to care for people in your busy practice, I want to highlight the ADA guidelines with this and the link that's here. The San Francisco General clinical resource website for diabetes is also extremely helpful. The link for that is here, and it includes a lot of great resources, including a cheat sheet for medications, supplies, and devices that are covered by the most commonly used health plans by the people that we're caring for. So just a reminder, back to the patient, some of the key labs that we had obtained when we confirmed that diagnosis of diabetes were a normal platelet count, an elevated ALT, and a borderline AST. So my next question for you is, what is the preferred screening test for metabolic-associated fatty liver disease for this person? Is it a FIB-4, an APRI, a NAFLD score, a right upper quadrant ultrasound, transient elastography, or none of the above because screening for MAFLD is not routinely recommended? Okay, in the interest of time, I'm going to move forward and we'll talk about why this is the case in just a sec. If you answered that screening for MAFLD is not recommended, you're in good company. Just a few years ago, both the AASLD and NICE recommended against screening for MAFLD for even for people with underlying risk factors, including obesity and type 2 diabetes, because of a lack of evidence that it was beneficial. However, several trends are changing how we think about that recommendation, including the fact that, as we know, metabolic-associated steatohepatitis and its complications are becoming increasingly prevalent in the population. And it's estimated that actually this is going to be the leading cause of liver transplantation at some point during this decade. Additionally, we're gaining more evidence for the efficacy of interventions to treat MASH. And lastly, we're gaining some cost-effectiveness data as well to support the implementation of screening in practice, at least for certain subgroups. So with all of that in mind, the AACE and AASLD in 2023 revised their guidelines and in fact did recommend screening for metabolic-associated fatty liver disease. And those recommendations have been adopted by the ADA guidelines as well. And these state that as your first screening test, you should actually do a FIB-4 so that you can also at the same time risk stratify for clinically significant liver fibrosis. Okay, and importantly, they note that you do not need to do an abdominal ultrasound to diagnose hepatic steatosis, and it's reasonable to move directly to that risk stratification. So this is what they recommend as a screening algorithm. Again, you're going to calculate the FIB-4, which you can do really easily because there's a dot phrase in EPIC that helps you to do that. If the results of that FIB-4 suggest that there's a low risk for advanced fibrosis, then you just have to repeat it in 2 to 3 years. If it's intermediate or indeterminate or high risk, then you're going to do another non-invasive assessment for fibrosis, whether that's transient elastography or an enhanced liver fibrosis test like the FibroScore. And then if that's high risk, they recommend referring to GI or hepatology. And but if it's low risk, again, you can just repeat your screening. I just wanted to highlight really quickly that just because we're referring those high-risk folks off to GI or hepatology does not mean that there's nothing that we as the primary care physicians for these folks can do. In fact, the ADA guidelines list a number of evidence-based recommendations that we can adapt into practice for our folks with MAFLD, particularly those who are at higher risk of fibrosis, including lifestyle modification, using either pioglitazone or GLP-1 RAs if they have MASH, and considering metabolic surgery to improve cardiovascular disease outcomes. And so for my last slide, I just wanted to ask the question, well, what about people with HIV who don't have diabetes? Should we be screening everybody with HIV for MAFLD? And the answer right now is that we don't know. The current AACE-AASLD guidelines do not list HIV as a specific risk factor for developing MAFLD. But I did want to draw your attention to this recently published study that prospectively enrolled over 1,000 participants from 9 centers across the US, including UCSF. Jenny Price was one of the co-authors, because this found that they found in this study that the prevalence of steatohepatic liver disease was very high, over 50% in the population studied. So while we can't say that HIV itself is a risk factor for MAFLD at this point, I think what we can say is that it is highly prevalent. So these are my take-home points. Again, I know that we're running a little bit tight on time, so I'm going to kind of let you stew on that slide while we transition to Jess and the next segment of the presentation.
Great. So I'm going to move on to the next case. So this is a 60-year-old man, history of HIV on ART, nicotine dependence, depression, alcohol use disorder, and remission. I'm coming in for routine follow-up. And the main thing he wanted to discuss are bothersome urinary symptoms for the past few months, including frequency and urgency. And these symptoms are really affecting his quality of life and also his income. He's working as an Uber driver and needing to stop between rides to find a bathroom. And finally, he's concerned about whether this could be a sign of cancer. So a little bit more about his past medical history. His medications are just Big Tap FTC and nicotine patches. You do an exam, he has normal vital signs, and as a thorough primary care doctor, you check for suprapubic tenderness. There is none, and on digital rectal exam, no masses or prostatic enlargement. On his labs, CD4 T cell count is 560, viral load is less than 30. His renal function is normal, and his urinalysis is unremarkable. So at this point, what next step would you recommend? Would you check a serum PSA and a post-void residual urine? Would you start tamsulosin 0.4 milligrams daily? Would you recommend lifestyle changes? Or would you evaluate symptom severity with a standardized questionnaire? I'll give you a moment to think that through. Right. So a few different thoughts here. So I guess I'll say probably all of these are reasonable at some point in this patient's management, but I'll share why I think D is the correct answer in terms of the next step. And in particular, speaking about the IPSS, or the International Prostate Symptom Severity Score. And this is a standardized 7-question self-administered questionnaire assessing the frequency and severity of lower urinary tract symptoms. It's been validated and translated into many languages. And just to note that it's not a diagnostic tool, so it doesn't necessarily tell you about the etiology of why someone's having LUTS, but helpful to evaluate symptom severity and monitor response to treatment over time. And this last one is the quality of life question. So I think if someone answers that they're delighted with their urinary tract symptoms, you probably don't have to do anything else after that point. So I'm just stepping back to talk a little bit about LUTS. This patient is assigned male at birth, so I'll be speaking a little bit more about that, but just want to acknowledge that LUTS are very common in the general population in both genders and increasing in age. So population level studies have reported 18% of men in their 40s and 50s with bothersome urinary symptoms. And over 65 years, it seems to be the norm rather than the exception to have some of these symptoms. And on the right, there's a table sort of dividing into typical categories. So storage symptoms, including urgency, frequency, and incontinence. Voiding symptoms, which are more of the obstructive variety around slow stream, needing to strain to urinate. And sometimes we also include post-micturition symptoms like dribbling or a feeling of incomplete emptying. There's a variety of etiologies for LUTS. In people assigned male at birth, BPH is by far the most common, and that's what I'll be speaking a little bit more in detail about. But other common causes include overactive bladder, systemic disease like diabetes and cardiovascular disease. Don't forget to ask people about their medications. Common culprits are diuretics, antihistamines, and antidepressants, and then rarely anatomic abnormalities or malignancy. And as I mentioned earlier, BPH is the most common cause of LUTS in male patients. Technically, BPH, or benign prostatic hypertrophy, is a histologic diagnosis referring to the proliferation of smooth muscle tissue in the prostatic transition zone. And benign prostatic enlargement is what causes bladder outlet obstruction and contributes to these LUTS symptoms. So just to clarify those terms. And I also wanted to point out that HIV is an independent risk factor for bothersome LUTS symptoms. Dr. Breyer, who actually will be speaking more on this topic in a few weeks, did a community survey a few years back looking at over 1,800 MSM and found that people living with HIV were twice as likely to report bothersome LUTS symptoms even controlling for other comorbidities. And I don't think that's necessarily clear exactly why that is, but something to be aware of, that it's particularly important to ask your patients as they age. So just a nice illustration of why it is that benign prostatic enlargement would cause these lower urinary tract symptoms. You can see in that transition zone that an enlarged prostate is kind of pressing on the bladder outlet and causing urinary obstruction, and also can cause functional symptoms. And then also going back to the patient's question, could this be cancer? Just a reminder that the prostate histologic zone, so the transition zone, is typically where we see benign prostatic enlargement and the cause of these lower urinary tract symptoms. The peripheral zone is where we generally see prostate cancer. And so very unlikely that urinary symptoms are related to prostate cancer. And conversely, prostate cancer, particularly in earlier stages, is very unlikely to be symptomatic at all. And so that's a whole different conversation about how we diagnose prostate cancer. So how do we manage LUTS? So the American Urological Association guidelines, which were recently updated, recommend discussing 3 categories of interventions. So lifestyle and behavioral interventions, medications, and surgical interventions as possible treatment options based on patient preferences. And so what are those lifestyle modifications? Things like limiting fluid intake, particularly before bedtime or travel, limiting intake of mild diuretics like caffeine, alcohol, and bladder irritants, avoiding constipation, increasing activity, and then behavioral interventions like timed voiding, double voiding, and pelvic floor muscle training. And this is a study that recently came out. I like this study because it's very pragmatic. It took place in the UK, and it's a multi-center randomized trial looking at primary care practices in the UK. And they just recruited men over age 18 years who had currently at least one bothersome LUTS symptom. And they randomized them to being provided with a standardized booklet with guidance on conservative management. And they also had a nurse who helped point them towards guidance that was particularly for the symptoms they were complaining about. And in a follow-up of over 1,000 patients at a 12-month assessment, they found a significant reduction in IPSS score. And so I think this is just confirmation that providing this counseling in a standardized way can be effective for patients. In terms of medications, there's a few different options in terms of classes. We often go first for alpha blockers, which have the highest level of evidence and tend to act more quickly than other classes. And there's a few different options. And since we'll be having urologists come in and speak, I won't get too into depth about that, but they have different side effect profiles. And so it's worth discussing with patients and thinking about their comorbidities when deciding on which one to select. 5 alpha reductase inhibitors, like finasteride and dutasteride, work by actually shrinking the prostatic tissue. And so they take longer to take effect. The Urological Association recommends these as monotherapy only in men who have enlarged prostates, either on exam, imaging, or by PSA. But they can also be considered as dual therapy along with alpha blockers for people who want to prevent progression of disease. And then these other classes, I think we use less frequently, PDE5 inhibitors. Good luck getting those with insurance, but can be an option, particularly for people with concomitant erectile dysfunction. And then anticholinergic and beta-3 agonists, particularly may be helpful for people with more storage symptoms like frequency and incontinence. Of course, we're all highly aware that anticholinergic medications can have a lot of side effects, particularly in older patients. And so you want to carefully weigh the risks and benefits for those patients. and check a PVR prior to initiation, since they can exacerbate urinary retention. So when should we refer to a specialist for consideration of surgical intervention? So as I mentioned earlier, the guidelines suggest that anyone can be referred if they're interested in surgical intervention as their primary mode of treatment. But certainly anyone who has is unwilling to take medications or has symptoms that are refractory to medications or is suffering complications of BPH, such as renal insufficiency, refractory urinary retention, recurrent UTIs, or recurrent bladder stones, or gross hematuria would be appropriate to refer. And finally, just to go back again to the patient's concern about cancer risk. So I included here the USPSTF 2018 recommendations around screening for prostate cancer. There's a level C recommendation in men aged 55 to 69 years. And basically to have a discussion with patients and make an individualized decision on periodic PSA-based screening based on the risks and benefits, including consideration of race, ethnicity, family history, and values and preferences. And then a recommendation against screening with PSA for men older than 70 years. I will note that this recommendation guideline is in the process of being updated. And I think some of the evidence that they're considering are the use of cancer risk calculators and MRI imaging to help risk stratify prior to biopsy and invasive procedures. So hopefully we'll have some updated guidelines soon. And then I also just wanted to include that. So for folks who are on ARIs like finasteride or dutasteride, which shrink the prostate, if you are measuring PSA for cancer screening, you should double the value to accurately gauge disease progression. Okay, so moving on. What additional screening should be offered for this patient? Should you offer a PHQ-2, a chest CT, an audit C questionnaire, or an ECG? All right, so we have a little bit of a split here. So I'll admit this is a little bit of a trick question. So I'm gonna say chest CT, but I'll acknowledge, so PHQ-2 is a great screening tool for depression. This particular patient has a diagnosis of depression, so you don't need to screen in them. You can use the PHQ-9 to monitor treatment. And likewise, the audit C is a great questionnaire to assess for alcohol use and dangers around alcohol use. But this again is somebody with a history of alcohol use disorder. And so you don't necessarily need to screen for that. So why are we screening with a chest CT? So this is somebody who has a history of smoking. And the US Preventive Task Force does recommend lung cancer screening with annual low-dose chest CT in adults 50 to 80 years who have a 20-pack year history of smoking and are either current smokers or have quit within the past 15 years. And just wanted to point out that non-AIDS defining malignancies represent an increasing proportion of cancer incidence and all-cause mortality among people living with HIV. This chart on the right is from a modeling study looking at cancer incidence in the US and people living with HIV in 2010 and 2020, and then projecting out to 2030. And you can see that the top three types of cancer are shifting increasingly towards non-AIDS defining malignancies. And in particular, lung cancer incidence and mortality are higher among people living with HIV than in the general population. Part of that is due to higher smoking rates, but there's also appears to be some biological vulnerability, perhaps related to inflammation or past infections, which I won't get into. And then also among people who were diagnosed with lung cancer, there have been historically treatment disparities among people living with HIV, which may also affect mortality. So why screen for lung cancer? Lung cancer is the leading cause of cancer death in the US, including among people living with HIV. And it has a poor prognosis, largely because it is generally diagnosed at late stages. And many of you may recall in 2011 when the first large randomized trial of lung cancer screening with chest CT was published and found to reduce lung cancer mortality. And a few years later, that was the NLST study. A few years later, another study from Europe, the Nelson study, had similar findings. Recently, a Cochrane systematic review came out looking at 11 randomized trials of lung cancer screening using low-dose chest CT and confirmed those findings that 21% reduction in mortality from lung cancer, a number needed to treat of about 226, and a 5% reduction in all-cause mortality. So we can certainly prevent cancer deaths and mortality in general by using this tool. And I also wanted to point out that the 2021 USPSTF recommendations were a change from the original recommendations in 2013. And specifically, they lowered the age threshold from 55 to 50 years. So it's now starting at 50 years. And they lowered the pack year threshold history from 30 to 20 pack years. And there's a couple of reasons for this. One were modeling studies that demonstrated greater reductions in lung cancer mortality. But really importantly, the US Preventive Task Force was also taking into account equity and disparities around Black and Latinx persons and women who are less likely to be eligible for screening when excluding smokers with lower pack year histories. And although they didn't explicitly discuss this in the guideline recommendation, this is also true of people living with HIV, that they're more likely to be diagnosed with lung cancer at earlier ages and lower pack years. So I think this also benefits our patient population, this change. So how are we doing? We're now 10 years out from that original recommendation to screen for lung cancer. There's been extremely low uptake of lung cancer screening around the United States. 3% between 2010 to 2015, now maybe up to 17%. Among those who are screened, there's low adherence to screening intervals, which is important because really the mortality benefit comes out of at least 3 screening intervals from data from those original studies. And then among those who are screened, there are racial disparities as well. So I think we can all do better to offer lung cancer screening to those who are eligible. And I'll put a shout out for the SFGH pulmonology service, are very helpful in terms of if your patient has a lung nodule on a chest CT, they have a low threshold to help assist in assessing next steps. And finally, just wanted to also give a shout out to smoking cessation as the most effective lung cancer prevention screening tool. On the right, that's from a study that's almost 10 years old now, but I think it's really powerful in just reminding us the life years potentially gained from quitting smoking among people living with HIV. We know that brief advice on smoking is effective. We had a great grand rounds on medication options a couple of weeks ago, and other resources include the California Smokers Quit Line, 1-800-NO-BUTS, and there are smoking cessation support groups here at the General. You can enter an e-consult if a patient is interested. All right, I'll move on to the last case. So this is a 46-year-old transgender woman, history of HIV on ART, hypertension, PTSD, chronic pain syndrome. She's coming in for routine follow-up, and she actually has no complaints, just coming in for a regular appointment. Her medications include intramuscular cabotegravir rilpivirine, intramuscular estradiol, topical diclofenac, and a combination blood pressure medication. In terms of her social history, she lives with her male partner and their puppy. She occasionally uses alcohol, but no other substances. And is asking, well, do I need to be checked for anything else since I'm here? So what other screening would you offer her? A PSA, a GAD2, an abdominal or aortic ultrasound, or a urine toxicology. Okay, so we got a bit of a split between B and C here. So I'll argue that the answer is GAD2, but I will take a moment to point out that if somebody has a prostate, regardless of their identified gender, you could offer PSA screening if they fit criteria. She's a little young at age 46, but if she were 55 to 69, that could be offered. Of course, we don't screen with urine toxicology for anything. So why are we screening with a GAD2? Just this past year, the US Preventive Service Task Force came out with a recommendation to screen for anxiety disorders in adults under age 65. And anxiety disorders are a group of psychiatric disorders defined by excessive fear or worry over everyday events. These are the common DSM-5 diagnoses under the rubric of anxiety disorders. They have a high burden of disease in the US and worldwide. One estimate is that lifetime prevalence is 34% in the US, which almost certainly increased during the COVID pandemic as well. It's the most common psychiatric are the most common group of disorders after depression. Anxiety disorders are also more prevalent in people living with HIV. One study from the Medical Monitoring Project found that 19% of people living with HIV experienced generalized anxiety symptoms compared to 6% in the general US population, and is associated with stigma as well as other mental health comorbidities, in particular depression, PTSD, and substance use disorder. And so how do we screen, since this is the recommendation now? Both the GAD2 and the GAD7 are the most frequently used and well-studied screening instruments. This is the GAD7, and the GAD2 is actually just the first 2 questions on that questionnaire. They have pretty good sensitivity and specificity for diagnosing, for detecting generalized anxiety disorder, less so for some of the other anxiety disorders. So for this patient, you administer the GAD7 and your patient's score is 12, which is concerning. And so you discuss anxiety symptoms with her, how they're impacting her life, and you assess that she likely has generalized anxiety disorder. So you provide a warm handoff to your team social worker, who discusses options for mental health care and referral to community therapy with her. And she calls to follow up and finds out that there's a wait list of 3 to 6 months, which is pretty typical, I think, in the community. So is there anything you can do as a primary care provider for this patient? And so I'll just go through recommended first-line treatment options for anxiety. So CBT is the most well-studied therapy, and that sometimes can be the one most hardest to access in the community. But supportive therapy, mindfulness-based stress reduction, and exercise also have good evidence for helping treat anxiety disorders and maybe a little bit more accessible, particularly in the short term. In terms of medication options, SSRIs and SNRIs are considered the first-line treatments for anxiety disorders. And then there are several medications that can be used as needed that have good evidence, including hydroxyzine and pregabalin. Gabapentin a little bit less well studied, but being very similar in drug class to pregabalin is also a reasonable medication to consider. For patients who haven't tolerated SSRIs or are not willing to try them, bupropion and buspirone are also options that have been studied, and there's some promising clinical trial data on herbal medications, including lavender oil, although those are not well regulated in the US. So just an asterisk on that. There was a study that came out earlier this year looking at comparing mindfulness-based stress reduction to escitalopram for anxiety disorders. And it's a high quality randomized control trial, enrolled patients from academic medical centers with a diagnosed anxiety disorder. And basically the intervention was either an 8-week mindfulness-based stress reduction course, which is not administered by a therapist, but it was protocolized versus the use of escitalopram. And they found that both groups demonstrated significant improvement in anxiety symptoms, and achieving non-inferiority criteria. And the group that was on escitalopram had a higher rate of adverse events. So I think a great option for patients who don't tolerate or don't want to take medication. So in terms of other low barrier anxiety resources for patients, there's some great apps out there. These are a few that are free. For patients who are interested in mindfulness-based stress reduction, there are actually websites that have the protocolized course online available for people to do in a self-guided way. And then here at Word 86, Alberto, our social worker, leads 2 different psychoeducation groups that can be a great resource for patients. City College actually has a free course on mindfulness-based stress reduction. And for patients with substance use, the Harm Reduction Therapy Center is a really great option for drop-in, really low barrier mental health. So my final take-home points: use the IPSS to monitor LUTS symptoms, and don't forget to discuss lifestyle and behavioral interventions for treatment. Recommend lung cancer screening with low-dose CT for patients 50 to 80 years with a 20-pack year smoking history, either current smokers or those who have quit in the past 15 years. And screen for anxiety in all adults aged, this should actually be 18 to 64 years technically. And GAD2 and GAD7 are great, well-validated screening tools. Thank you.
Thank you. Truly tour de force. I'm going to take some questions from the audience while I log in to Zoom.
Hi, thanks so much for a great talk. I have 2 questions, if that's okay. So my first question is on weight and body composition. Have you had any experience, or what are your thoughts on using other metrics besides waist circumference? So thinking about DEXA or in-body and some of these electrical impedance tests. And then my second question is for diabetes screening and for people with HIV, your thoughts on fructosamine.
I guess I can answer from here. Yeah, so for the first question, in terms of the current guidelines, I think the waist circumference is simple, it's easy, it's totally inexpensive, and it has been shown to correlate fairly well with metabolic risk. So I think as a screening tool, it makes sense to use that as opposed to the higher cost other tools that you're recommending. In terms of using fructosamine, that is an option, but it's more, again, it's more expensive and not necessarily as readily accessible as just doing the plasma glucose-based criteria, which is why that is what's recommended. So, but good question. And for people with other disorders that can impact the A1C's correlation to plasma glucose, fructosamine is sometimes recommended, particularly for hemoglobinopathies and other disorders like that. But for HIV, not yet.
Thanks for a great talk from both of you. I have a comment and then a question. So the compliance with my patients with coming in for something fasting is almost zero. So I just want to recognize that you know, often I'll just get lipids and an A1C, and those are good tools. So I wouldn't discourage people from screening for diabetes if we're only relying on a test that they may not be able to complete given their life and what's going on with them. So just wanted to make that comment. And as a corollary to that, maybe pioglitazone, boy, with all the tools that we have for a drug that makes you gain weight and increases your risk for heart failure, I can't find a time that I would ever use it. So for me, I just feel like pioglitazone is not. I understand that it's on the guidelines. The question I have for you is about semaglutide and the SELECT trial, and whether you would, I know that they sort of equivalently, and the guidelines, I can't be updated in real time, but would you choose now semaglutide over an SGLT inhibitor? They're sort of listed similarly for people who have a risk for coronary artery disease based on the SELECT trial, which was pretty impressive. And then you also have the weight loss benefit there as well.
Right. So in terms of your first comment, Annie, it's a great comment. And I will be honest and say, I actually don't do fasting labs on folks. And so if their random glucose is abnormal, just like if their random triglycerides are really abnormal, then I will ask them to come back in for fasting labs in that case. But otherwise, I'm not doing that. But it's still, I mean, we usually get the glucose as part of the CMP or BMP, whatever we're doing yearly anyhow. So that's kind of how I deal with that in practice. But it's a point well taken, and I appreciate your stating that. I don't have a specific opinion on semaglutide. I'm not as familiar with the SELECT trial, so I would have to go back and look at those data to see. Yeah.
Reduction of relative risk reduction of 20% for people with known coronary disease.
And yes, and obesity, but without diabetes. Is that right?
Correct.
Yes, without diabetes. Okay. Yeah. I mean, compelling evidence. Right? Very compelling evidence. So, and I think there are growing data to support the use of GLP-1 RAs for a lot of different conditions, including metabolic associated steatohepatitis. The reason I highlighted pioglitazone, at least in Massachusetts, where I practiced, it was often very difficult to get GLP-1 RAs. And so I do think that there is a potential niche role for folks with diabetes who have MASH, but who cannot access the GLP-1 RAs to provide some benefit in that particular population.
Thank you. We are a bit over time, but I know we have one more question. Monica, you want to ask your question quickly?
Well, that was so useful to us. Thank you so much. Do you think the 4 things we should do at Ward 86 then are glucose screening, CT, which we've not done at all, lung cancer, think about our PSA, and then incorporate anxiety screening more? Is there anything else that we should be, because this is part of the Revival of Care initiative. We have to be better at screening.
Yes, I personally think we need to revive lung cancer screening. I think there's very clear evidence that it reduces mortality. So if there's one takeaway from my portion, I think, yes, we all need to be better about that, and I'll include myself in that.
And you can, I mean, I refer people all the time. They do it, it's great. The system works well. Low dose CT.
Just the order for our hospital is just non-contrast chest CT, and if you just put in the comments that you're referring for cancer screening, they'll protocolize it accordingly.
They
Yeah.
do a great job. Okay. Thank you so much.
Thank you.